Hello, welcome back. I'm Dr. Mark, and today we're going to review diabetic neuropathies. Of course, this is a very severe and a very common source of disability for patients with diabetes. So today we are going to review what is this neuropathy. In future videos, we are going to focus a lot more on treatment and prevention. In this first video, just understanding what is it and why does it appear in patients with diabetes. So let's start. So what is diabetic neuropathy? It's an often irreversible damage to nerves and glial cells due to high glucose levels. We're going to review in a bit that this nerve damage is more often encountered on peripheral nerves. Central nerves can also be altered or damaged, but since we have the blood-brain barrier, it is often much later in the timeline of a patient with diabetes. It's one of the leading causes of disability and poor quality of life in diabetes, since it causes a lot of pain. It can cause falls, it can cause autonomic diseases from arrhythmias to alterations in our gastrointestinal tract, nausea, diarrhea, very chronic, difficult to treat diarrhea, incontinence, so patients lose urine or feces without control, etc., etc. And of course, all of this can lead to very poor quality of life. The same way as peripheral nerves are often affected earlier in diabetes, we can also, and we will see it in a moment, but there are types of nerves that are more easily altered. So sensitive nerves are often some of the most frequently affected, and that's why pain is also very frequent. 50% of patients with diabetes have diabetic neuropathy in some point of their disease. So it's a very prevalent complication in these patients, and that's why we always have to prevent it, to look for it, and of course educate our patients to be focused on stopping this diabetic neuropathy. And the estimated cost only in the United States, I put the amount from the United States since it's one of the countries with the best tracking about financial issues, and they estimate that it costs them $10 billion annually to treat the complications of diabetic neuropathy. So it's not only a very severe and important problem for the patient, but for the healthcare system in general, and of course in the world. Now, this is what we were talking about. We can basically separate our nerves in two groups. We have the central nervous system. The central nervous system is our brain and, of course, our spinal cord. This is all protected with the blood-brain barrier, so it's relatively more resistant to diabetes. This does not mean that it's immune, so patients, when they have a long time with diabetes, a poor control, can experience things in the central nervous system like brain fog. It's a state where patients are confused, they are depressed, they think much slower, so they can have alterations in the central nervous system. However, it's much more frequent and it appears much sooner on the diabetes scale in the peripheral nervous system. So all of the nerves that come out of our spinal cord and our brain, and they are basically in our body, so to speak. Since they are nerves that are not protected by any barrier, but by the blood-brain barrier, and they are really exposed to blood and thus to high glucose levels, then of course these are the most severely affected or impacted by diabetic neuropathy, and these are the ones that we have to be constantly monitoring in patients with diabetes. These peripheral nerves can be divided in three main types. Number one, sensitive nerves. Of course, these generate the sensations. We can easily identify sensitive nerves because they generate basically touch. They can also give us pain perception, temperature perception, so if it's cold, if it's hot, if something's burning, all of that is sensitive. We have some specialized sensitivities. For example, proprioception, that is our perception of where is our body. If I ask you to close your eyes and without looking, if you could tell me the position of your fingers, of your hands, of your feet, you could do that because of proprioception. And we also have in the sensitive part of our nerves things very related to balance. So when we have a diabetic neuropathy affecting the sensitive nerves, we can have first a decrease in the activity of these nerves, so we don't feel properly. Then we can feel too much, like in painful diabetic neuropathy, a patient that is always in pain, especially in some regions, as we are going to check in a moment. But we can also have problems in balance because the body is no longer capable of knowing where is our feet, our hands, where is our torso. They don't communicate to maintain our posture. So all of these things can also be a characteristic of diabetic neuropathy in the sensitive branch of nerves. Those patients, when it's very much advanced, have chronic pain, very severe. They can't walk anymore, but it's not necessarily because the muscles and the nerves that go to the muscles are failing, because the body doesn't know any longer where is the other parts of the body. Then we can have autonomic nerves. These autonomic nerves are the ones that go to all of our organs, the heart, the stomach, the intestines, the bladder. They tell these organs when to work, when to activate. So if I start jogging, they tell my heart to beat faster, my intestines to work less because I am jogging, I'm not eating. And when I start eating, it's the opposite. So when we have an autonomic neuropathy, of course, all of our organs may don't do their function properly. We may have patients that when they wake up and rise from their bed, they collapse because the heart didn't compensate enough, raising our blood pressure to the upright position. Maybe we have a very slow beating heart when we are doing exercise. Maybe we eat and the stomach just doesn't move in something called gastroparesis. And thus we have nausea and we vomit food. We can't eat anymore. Or we may have diarrhea, chronic diarrhea. And as I was mentioning, we can have a hyperactive bladder that constantly eliminates urine when we don't want it to be eliminated, or with urine retention. And finally, we have motor nerves that, as their name suggests, they are in charge of motion, of the movement of our bodies. So these motor nerves are going to reach our muscles and they are going to tell them to move. Thus, when we have alterations in our motor nerves, the patient gets weaker and weaker until they can't move some part of the body or large parts of their bodies. Usually that's the order in which we are going to find this neuropathy. So first we are going to find it in sensitive nerves, then in autonomic nerves, and finally in motor nerves. This doesn't mean that from the beginning of the disease, again, a poorly managed diabetes, we can't find all of them. However, it is usually more severe and more and an earlier sign, the sensitive neuropathy, then autonomic neuropathy, and finally motor neuropathy. Why does neuropathy appears? What's happening in these patients? Essentially, first we have to remember that besides our nerves, we have a lot of other cells. These are called glial cells. They have very important purposes since they form, for example, the blood-brain barrier. They form myelin, the myelin sheath, that is essential for nerve transmission, and they have a lot of important functions. The main problem with a patient that has diabetes is glucose. Glucose is, of course, essential for our nerves and all of the glial cells. However, when we have very large amounts of glucose, this glucose transforms basically in a toxic substance. Why? Because all of this glucose can then bind to different proteins in our nerves and glial cells and start damaging them. They lose their function, and when the protein loses their function, then we are going to have that the whole cell loses its function. This cell damage, besides this direct toxicity caused by glucose, of course, is going to have several mechanisms of damage. First, the one I was explaining, non-enzymatic glycation of proteins. So glucose binds to those proteins and destroys them, basically, and then it destroys the whole nerve cell. We have the buildup of some toxic substances inside of our nerves, like sorbitol. We have something called Wallerian degeneration, that it's a very severe damage to the axon, to this like filament, like this line that connects one nerve to the other. So it basically gets cut, and thus the nerve dies, and of course the nerve can't talk with other nerves before dying. And finally, the buildup, just as we had with toxic substances such as sorbitol, we also find a reactive oxygen species building up in our nerves and, of course, causing damage to these nerve cells. This all of these mechanisms will appear and will be present as long as we have these very high levels of glucose. If we manage to lower these glucose concentrations in blood and in the space surrounding our nerves, of course our nerve will stop receiving damage. However, if the damage was severe enough, that nerve might not be able to repair itself and to recover from the damage caused by glucose. And what I'm trying to say from this is that diabetic neuropathy, in some very specific cases, if we find it in time, if we give an aggressive treatment, if we control glucose perfectly on those patients, it might be stopped and even kind of reversed. However, in most patients, diabetic neuropathy doesn't get cured, and in fact it progresses. So from the point that we see the patient 5-10 years in the future, it's very likely that that patient will have a more severe diabetic neuropathy. That doesn't mean we shouldn't do anything. Of course, a poorly taken care of patient is going to have a much more severe diabetic neuropathy. We have to be very aggressive to stop it, and to stop it as long as we can, and to prevent the spread of this neuropathy. However, we also need to manage the expectations of our patients and of family members. Diabetic neuropathy is often not reversible, and patients often progress with the diabetic neuropathy, once again, especially if they are not taken care of properly. Who gets it? Basically, a patient with diabetes with a prolonged disease. And although the prevalence is basically the same in type 1 and type 2 diabetes, we will find a very different timeline for patients with type 1 and type 2. Type 1 diabetes, we will find diabetic neuropathy a couple of years after the diagnosis, because we, of course, diagnosed the diabetes the very first day it was severe in that patient. In type 2 diabetes, we may often find diabetic neuropathy when we make the diagnosis of diabetes the very first day. Why? Because that patient probably had diabetes 2 to 5 years previous to our diagnosis, but didn't notice, and it's reaching us late. So when the patient reaches us with diabetes, we have to check for diabetic neuropathy, because it may appear just as we make the diagnosis of diabetes. Number 2, with age, as the patient ages and becomes elderly, the risk of neuropathy is much higher. So even if in a properly controlled patient, he or she may reach the diabetic neuropathy state, just because that patient is aging and the nerves can't keep up with all of the stress that are exposed to. Of course, the level of glycated hemoglobin, it's one of the main parameters of good or bad glucose control in our patients with diabetes. So a good level of glycated hemoglobin protects our patients. A bad level, a very high level, a level that is 7% or higher, is of course a risk factor for diabetic neuropathy. Patients with metabolic syndrome, this is patients with diabetes or with insulin resistance and other comorbidities like obesity, high lipids, cholesterol, triglycerides, hypertension, and other risk factors. A patient that smokes or drinks alcohol, or of course uses other substances or drugs that can damage the nerves. We of course already have a video about drugs that can cause neuropathy, so you might check it out. And finally, height. Taller patients, because of several reasons, have a high risk of neuropathy, especially in the nerves that are far away from their brain. So the taller a patient is, the higher the risk of diabetes. What are the types and distributions? We are going to see this with much more detail in future videos. However, the main distribution of diabetic neuropathy. So we basically find that the nerves that are further from the brain and the spinal cord are the ones most frequently altered or susceptible to diabetic neuropathy, and thus the hands are a common place to find diabetic neuropathy, and even more common, the feet and the legs. That's why every time we see a patient, especially a patient with type 2 diabetes mellitus, from diagnosis, we are going to check the nerve cells and how they are conducting impulses through our exploration in those patients with diabetes to detect this sensitive, at first sensitive, but of course also autonomic and motor diabetic neuropathy.
We might also find other distributions. They are less common, but usually they follow the tract of a nerve, a specific nerve. And finally, we may have autonomic neuropathy that follows the nerve of one organ. So we can have, as I was saying, heart arrhythmias because of the nerves of the heart. We can have gastroparesis, that's the basically paralyzing of the stomach, and thus we cannot eat properly. We can have alterations in the large intestine, leading to diarrhea, very difficult to manage chronic diarrhea, and finally the bladder, giving us a poor control over our sphincters. Finally, if we have patients that have diabetic neuropathy, we should think about other severe complications in diabetes. If diabetes has been strong enough, severe enough, and poorly controlled enough to bring damage to our nerves, we should also check our kidneys, our eyes, and of course all of the other organs affected by diabetes, but mainly these two. So we detect diabetic neuropathy, we should send that patient, if he or she hasn't gone recently, to the ophthalmologist to check for retinopathy, of course another severe complication of diabetes and another topic we will cover soon on the channel. And of course kidney function, because kidney function is severely altered by high glucose levels. Diabetic patients can have or do have a high risk of chronic kidney disease, and thus when we detect one, we should check the others. The same applies on the contrary. If we have a patient with chronic kidney disease due to diabetes, we should check the eyes and check the nerves of that patient. These complications usually go hand in hand, and thus we need to detect them all and prevent them all. Basically, that's the information we are going to see on this video. Here you have some of the reference I used for this video. Of course, very soon we are going to delve deeper into diagnosis, treatment, and other things of diabetic neuropathy. This was just the part 1 of this video, so expect the next videos very soon.
Well, this is it. Thank you very much for your attention, for watching this video, for sharing it, for liking it, and all the other things you do with these videos. That's all for today, and as always, help us change the world. Share the information.